into
At least it didn't happen in the lobby.
or in the ambulance. At the same time, they had two DOAs. I don't understand that.
Birth on arrival.
But if they birth before they arrive.
Is it not?
Not birth out of arrival.
What is it?
Yeah, but if they
Born out of
Asexual. Oh. I like mine better. Because everything's born out of asexual.
Anyway, yes, we get two at the exact same time.
The only thing I ever worry about was in here earlier.
There is something wrong with me. Because I think that today is my class, they're together. Your class is good. Dr. Shannon, whenever you want to get started, there's no one else out here.
Okay, great. We can go ahead and get started. All right. Good morning. This morning we're going to discuss patient safety and quality of care as it applies to obstetrics. An outline of the discussion today begins with the background history of patient safety, a description of the peer review process using a case-based example, a discussion of quality care measures, and a review of several quality improvement projects here at the University of Maryland Medical Center. As I prepared this discussion, I was interested to find out what sparked the patient safety movement. In 1999, the Institute of Medicine published a landmark report stating that healthcare in the United States was not as safe as it should be, and went on to report that more than 98,000 Americans die every year from preventable medical errors. As of 2013, patient safety experts have calculated that more than 250,000 deaths occur per year due to medical errors in the United States, and medical error is now the third leading cause of death in the United States. The original intent of the Institute of Medicine Committee on Quality Healthcare in America, who published the report, was to address an unrecognized component of quality, which is patient safety. The Institute of Medicine recognizes that most medical errors are not due to inherently bad doctors, and reporting of these errors should not be addressed with punishment or legal action. Most errors represent systemic problems, including poorly coordinated care, fragmented insurance networks, the absence or underuse of safety networks and protocols, and unwarranted variation in physician practices. The Institute of Medicine report outlined a four-part plan intended to create financial and regulatory incentives to create a safer healthcare system and a systematic way to incorporate safety into the process of care. The Institute of Medicine recommended the creation of the National Center of Patient Safety under the Department of Health and Human Services Agency for Healthcare Research and Quality. Second, the Institute of Medicine recommended establishing a nationwide mandatory public reporting system where federal legislation would protect the confidentiality of certain information. Next, the Institute of Medicine believed that a fundamental change would require pressure and incentives from many directions, including public and private purchasers of healthcare insurance, regulators, including the Food and Drug Administration, and licensing and certifying groups. Lastly, the Institute of Medicine urged the healthcare organizations to create a culture of safety as a top priority. Formed in the late 2011, the Council on Patient Safety in Women's Healthcare brings partner and subspecialty organizations in women's healthcare together with representative industry organizations with the central goal of improving women's health. Their mission is to continually improve patient safety in women's healthcare through collaboration that drives culture change. The Council on Patient Safety in Women's Healthcare purpose is to reduce harm by fostering investigation to better understand the cause of harm, programs and tools to implement patient safety initiatives, education to promote patient safety, dissemination of patient safety information, and a culture of respect, transparency, and accountability. The Council for Patient Safety has produced several core patient safety bundles that you are likely familiar with. These include maternal mental health, maternal venous thromboembolism, obstetric hemorrhage, and severe hypertension in pregnancy. A survey of hospital leaders conducted by the American Hospital Association found that newly trained physicians were deficient in the areas of communication, use of systems-based practices, interprofessional teamwork, and highlighted the need to educate U.S. physicians, residents, and fellows to address quality improvement. There are over 117,000 resident and fellow physicians in U.S. teaching hospitals. In our role on the front line of patient care, we need to be prepared to recognize patient safety events and intervene when appropriate, champion performance improvement efforts, and work effectively in the interprofessional teams on system-based issues. The Clinical Learning Environment, or the CLEAR Review program, is a component of the National Accreditation System, which was implemented by ACGME as a subsequent step in the evolution of graduate medical education. The CLEAR program is designed to provide U.S. teaching hospital, medical centers, and health systems and other clinical settings affiliated with ACGME to provide feedback that addresses the following 6 areas: patient safety, healthcare quality, care transitions, supervision, duty hours, fatigue management and mitigation, and professionalism. In this further discussion, we will talk about primarily patient safety pathways and the healthcare quality pathway. The patient safety pathway is made up of 7 sub-pathways. And to further the aim of the CLEAR program, ACGME has implemented the CLEAR Pathways to Excellence as a tool to promote discussions and actions that will optimize the clinical learning environment. The basic framework for the CLEAR Pathways to Excellence focuses on a series of pathways. Most relevant to our discussion, again, is the patient safety pathway and the healthcare pathway, healthcare quality pathway. Within the patient safety pathway, the first and one that I've highlighted here is reporting of adverse events and close calls. They also recommend formal education activities that create a shared mental model with regards to patient care. They recommend facilitating a culture of safety. And residents and fellows participate as team members in real or simulated interprofessional clinical site-sponsored patient safety investigations, such as root cause analyses. Next, the clinical site monitors the resident and fellow participation in reporting of safety events, and the clinical site should monitor the participation in reporting of faculty members, or the faculty members reporting safety events. And lastly, the residents and fellows should receive hands-on training on how patient safety events are disclosed to patients and their families. The reporting of patient safety events at the University of Maryland Medical System is through the RL6 reporting system. It can be found on the internet by clicking on the event report and using your username and password that you use to log into Epic. You can subsequently choose a particular category that applies to your safety event. Next is the healthcare quality pathway. I have highlighted resident and fellow engagement and quality improvement activities because we will review several of the quality improvement projects that are currently being conducted in our department. I would like to transition to a case-based example in order to illustrate the peer review process and describe a root cause analysis. Some of you may be familiar with the Swiss cheese model and some for the first time. This is a way to illustrate why adverse events happen in medicine and large organizations. Each slice of cheese represents a safeguard against a potential hazard, the healthcare system in direct contact with patients, coming up with the right treatment plan. This person does not work on an island, and the rest of the treatment team, students, nurses, pharmacists, and others working together should prevent these hazards from occurring. The EPIC should flag certain medication interactions or alarms, and organizations employing checklists and timeouts before surgical procedures. Holes represent the weaknesses in our system. The presence of any one hole does not normally result in an adverse event. It acts as another defense layer and will identify the problem and stop and mitigate the event. So our patient is a 38-year-old G2P1001 at 34 weeks and 1 day who presented to the outside hospital with nausea and vomiting and abdominal pain. The patient was diagnosed with HELLP syndrome and transferred to a tertiary care facility. The patient's past medical history was notable for a history of lupus with underlying chronic kidney disease with a baseline creatinine of 1.4. Past surgical history was remarkable for a history of 1 low transverse cesarean section at term. The patient was started on magnesium sulfate and underwent a trial of labor. Throughout the patient's intrapartum course, her platelet count nadir was 74, maximum AST was 158, ALT was 177, and her maximum creatinine was 2.8. She required several doses of IV labetalol. The patient had a successful vaginal birth after cesarean. The patient's postpartum course was complicated by an immediate postpartum hemorrhage from uterine atony that responded to hemobate and Pitocin. Her total EBO was 1,000 cc's. The patient received 2 units of emergency released packed red blood cells because she did not have an active type and cross and did not have blood available. She was transferred to the IMC for her postpartum management due to the need for a bed on labor and delivery. The patient complained of abdominal pain postpartum and was evaluated by the intern on several occasions. The physician was reassured by the patient's normal blood pressures and absence of tachycardia. Repeat labs were not obtained. Approximately 8 hours after the delivery, the patient's nurse called a rapid response because the patient had altered mental status. Review of her labs showed a hemoglobin of 6, and physical exam findings consistent with hemoperitoneum and was taken to the main operating room. Intraoperative findings included a ruptured uterus. The patient received a total of 8 units of packed red blood cells, 6 units of FFP, 2 packs of platelets, and cryoprecipitate. In the PACU, the patient experienced cardiac arrest in a setting of pulmonary edema. She had return of spontaneous circulation after 4 minutes. The patient was transferred to the ICU. Detailed review of her eyes and nose showed that the patient was positive 6 liters for her admission. It is important to note that the procedure was performed in the general OR, and the patient was taken to the OR PACU for recovery. The OB team left the PACU once the patient arrived in order to manage a complication on labor and delivery. The OB team left PACU prior to receiving anesthesia sign-out and was unaware that the patient's respiratory exam was significant for crackles that were concerning for pulmonary edema. The anesthesia resident forgot to tell the OB team that the patient needed an order for Lasix when she got to the PACU. In the next section, we will review the debrief, the peer review, and the root cause analysis using our case-based example. There are only a few examples in the literature to guide a debriefer with regards to the important elements to discuss during a debrief. An immediate debrief following an adverse event or simulation has proven to be one of the most effective learning tools. An effective way to generate notes, and an effective way to generate a timeline of events with regards to the event. One example of a debriefing tool is the diamond. The diamond was initially designed to provide a structure for the simulation debrief and is applicable to real-time debriefing. The diamond debriefing model, which is a structured visual reminder of the debrief process, is based on a technique of description, analysis, and application, along with aspects of advocacy and inquiry approach in debriefing with good judgment. Here I've shown a copy of the debriefing tool that we use on labor and delivery. Some of the elements that prompt a debrief listed on our debriefing tool include a shoulder dystocia, umbilical cord prolapse, uterine rupture, placental abruption, failed operative vaginal delivery, hemorrhage, code, and emergency on mother-baby unit. Our debrief is a series of 9 questions and provides a final disposition. It also has a spot on there that you can, that's a checkbox for signifying that you have documented this adverse event in the RL6 or you've notified the risk manager. The process of peer review is designed to have tiers of review that allow for most issues to be handled at the level of the clinical department. Peer review will initially be at the departmental level, except when at the discretion of the University of Maryland Medical Center Peer Review Committee, a matter is considered sufficiently serious, such as to merit immediate review of the Peer Review Committee in collaboration with the departmental review. The Council on Patient Safety and Women's Health makes the following recommendations for events that should be reviewed. These include pregnant or peripartal or postpartum women receiving 4 or more units of blood products, pregnant, peripartal, or postpartum women who are admitted to the ICU as defined by the center, and other pregnant, peripartal, or postpartum women who have an unexpected and severe medical event at the discretion of the facility. Several adverse events that are tracked across the University of Maryland medical system include maternal death, uterine rupture, return to the OR after delivery, stillbirth or intrapartum fetal demise of a fetus weighing greater than 500 grams, neonatal death, and trauma to the baby during the delivery, including brachial plexus injury, any limited movement of an extremity with or without a shoulder dystocia, and any laceration of the baby at birth requiring sutures or staples, or sutures or steri strips, sorry. Triggers for our review in our case included a postpartum hemorrhage with transfusion of more than 4 units of packed red blood cells, return to the OR, ICU admission, and cardiac arrest. Who should attend the review? This is a multidisciplinary standing committee at the facility that represents the obstetric providers involved in the event, anesthesia providers, obstetric care nurses, a facility quality improvement team, facility administration, should be consideration to have a patient advocate present, a scribe, and if this is being performed at a small center, consider partnering with a regional perinatal center. Critical to the improvement of patient safety and quality is a culture of structure that supports clinicians in performing their role effectively and safely. A key component is such a culture that is transparent, evaluation of potential errors, using the structured process to both analyze serious events and investigate system vulnerabilities. Many organizations use a root cause analysis to determine the underlying cause of the events. The decision to use a root cause analysis or other comprehensive systematic analysis is at the discretion of the leadership of the facility. Even for facilities who are experiencing at conducting root cause analyses, the process can be fraught with inconsistencies, provoke discomfort for participants, and fail to lead meaningful, focused discussions of system issues that have contributed to the event. Having the ability to quickly focus energy and resources in response to a sentinel event enables a healthcare organization to identify issues and changes to improve healthcare. A novel approach to conducting a root cause analysis was developed by the University of Kentucky Healthcare System and is called the SWARM process. SWARM is a consistent RCA approach that provides centralized support to investigate events, focuses on improving system performance, and rather than identifying individuals to blame. Notably, SWARMs are protected from discovery in legal proceedings under the Patient Safety Act. The SWARM process should take place in a neutral location typically hosted in the same room in the hospital with access to the electronic medical record. A circular seating arrangement facilitates conversation, and the primary goals of the swarm are to find out what happened, why it happened, and how to prevent it from happening again. The first part of the swarm is an introductory explanation of the process with a description of the plan and the purpose, and the reassurance to the participants of the swarm will be conducted in a blame-free environment. The next step is to introduce everyone in the room so that there's familiarity combined with emphasis on respect for everyone so that the group can attack the problem instead of attacking a particular person. The next step is to review the facts. Next, there's the discussion of what happened and an investigation of the underlying system factors and theorizing why it happened. During this step, participants often rely on multiple tools to structure the conversation and clarify the problem, such as a timeline, flowchart, fishbone diagram, or the 5 whys. The swarm concludes with proposed focus areas for action and assignment of task leaders. After coming to a shared decision of what has happened, the team begins brainstorming fixes. Was this a staffing issue? Were there cultural issues such as poor communication or steep hierarchies? Does the process need to be standardized or simplified? Would a checklist help? The last 10 minutes of the hour are devoted to creating a formal action plan, and individuals are charged with completing further investigation and implementing that plan. I have created a fishbone diagram to help guide the root cause analysis for our particular case. For disease and patient factors, the patient's underlying chronic kidney disease with elevated creatinine and HELLP syndrome certainly contributed to our adverse outcome. The patient was more susceptible to impaired clearance of magnesium, magnesium toxicity, volume overload, and pulmonary edema. The patient was also at increased risk for postpartum hemorrhage due to her history of prior uterine surgery as well as HELLP syndrome. There were not any surgical judgment or surgical technique errors in our case. There were multiple lapses in communication, including the OB intern who did not review or discuss the postpartum management with their chief resident, the anesthesia staff who forgot to tell the OB resident that the patient needed an order for Lasix, and the OB team leaving the PACU prior to the anesthesia handoff, as well as there was a delay in communication from the nurse in the IMC with notifying the attending physician or the chief resident when they felt that they needed further evaluation of the patient. There was a delay in diagnosis of hemoperitoneum, likely caused by the patient's, quote, normal vital signs. There was medical knowledge error that a patient with normal vital signs, with normal blood pressure that previously required IV antihypertensives and was oliguric probably had the potential for bleeding, could have had concealed bleeding. And in addition, a patient that received IV labetalol that did not have tachycardia. Another contributing factor was that this critically ill obstetric patient was moved to the IMC due to the bed availability for laboring patients. All events reviewed by a swarm are entered into a database and are classified according to their contributing factors. Events can have multiple contributing factors, as seen in our case. We had communication, resident to resident, communication escalation, as well as clinical deterioration that went unrecognized, and care coordination. After identifying the contributing factors for the event during our peer review, we developed an action plan to address the contributing factors as well as several opportunities for quality improvement projects. Communication between the OB intern and the chief resident. It is now a standing rule that the intern must review the care of all postpartum patients with the chief resident when they receive a call from the nursing staff to evaluate a patient. And I will review the communication between the OB team and the anesthesia staff towards the end of our discussion when I review anesthesia hard stop. The clinical nurse has been tasked with notifying the charge nurse of any concerns that they have and immediately contacting the chief resident or the attending physician to evaluate a patient. The clinical nurse should use SBAR scripted communication when speaking to the physician and document in the medical record that a provider has been notified and expect a provider to evaluate the patient within 15 minutes. To address the medical knowledge errors, we have conducted simulations in postpartum hemorrhage and reviewed maternal early warning signs. Another quality improvement project that I will discuss shortly is pause before pushing. Pause before pushing would have identified that the patient did not have an active type and cross and blood readily available, despite having a history of prior uterine surgery and HELP syndrome. Lastly, care coordination with transferring the patient to the surgical intensive care unit will be addressed with was addressed and will be reviewed with the newly formed guidelines for the critically ill obstetric patient. Early warning systems have been proposed to facilitate timely recognition, diagnosis, and treatment of women developing critical illnesses such as hemorrhage, hypertension, hypertensive crisis, sepsis, venous thromboembolism, and heart failure. The maternal early warning criteria are a list of abnormal parameters that indicate the need for urgent bedside evaluation by a clinician who has the capacity to escalate the care and order diagnostic and therapeutic interventions. Critical components of an effective communication policy should define who to notify, when to notify, and how to notify that person. Our patient had oliguria, which should have prompted a more thorough and timely evaluation. The next section will review the quality of care using our case-based example. Recently, there has been pressure on hospitals and physicians to measure quality of care to improve the adequacy of the care that they are delivering. But how does one measure quality of care? Performance measures have been created by a number of advocacy coalitions, patient safety initiatives, government agencies, and professional organizations. To measure performance adequately and accurately, the Agency for Healthcare Research and Quality defined 5 key components. These include access, structure, process, patient experience and satisfaction, and outcome. The most commonly studied measures are structure, process, and outcome measures. None of the 3 categories is superior to the other, and some investigators suggest that the simultaneous examination of measurements of all different types allows a greater understanding of the quality environment. Structure capacity measures are designed to assess whether the capacity to perform a service or function exists in a particular system. For example, what portion of providers have completed a certain postpartum hemorrhage training, or whether a particular service is available at an institution, such as a postpartum hemorrhage cart or a massive transfusion protocol. Structure and capacity measures are designed to assess whether the capacity to perform a certain function. Process measures are designed to assess the frequency of usage of a particular clinical process. For example, the number of patients with a fetus with an estimated fetal weight less than 1,500 grams gets delivered at a tertiary care facility with the appropriate level of care. Other examples include the appropriate use of antibiotics for cesarean deliveries, the administration of antenatal corticosteroids, and DVT prophylaxis in surgical patients. Process measures are popular because they reflect actions of the care system and thus are able to be directly influenced by the health system. It is well known that even good care can be associated with bad outcomes, and thus measuring the process can ensure that a hospital gets credit for what it does correctly. Outcome measures are created by assessing the frequency of and prevalence of a specific outcome in a given population. Examples include obstetric anal sphincter injuries, operative vaginal deliveries, neonatal brachial plexus injuries, ICU admissions, severe maternal morbidity, maternal and neonatal mortality. Many of the current metrics being tracked are outcome measures. chosen due to their ease of measurement, but they're criticized by many clinicians as being an end product that may not truly reflect quality of care. When looking at outcomes, it may be important to take into account the differences in patient populations that can affect the outcome. Taking patient characteristics into account is known as risk adjusting. Access measures assess the attainment of patients of timely care, as well as the delays and barriers, such as educational, financial, prejudice, geographic, and environmental that may result in a failure to obtain care. And patient experience and satisfaction measures assess the patient's perception and the experience of the healthcare delivery. To continue to work towards the national goal of improving and optimizing maternal health, maternal and perinatal outcomes, selecting specific metrics has become the national priority areas, and it serves as an important and effective strategy. Obstetric providers have grown increasingly frustrated with quality measures that poorly represent provider and hospital quality. Providers desire a healthcare system that is patient-centered, efficient, effective, safe, and timely. In February of 2016, the Society for Maternal-Fetal Medicine, the National Institute of Child Health and Human Development, and the American College of Obstetricians and Gynecologists convened a Quality Measures in High-Risk Pregnancies workshop. The committee selected 6 topics to focus on for this workshop. This included preterm birth, screening, prevention, treatment, as well as preventing the first primary cesarean delivery, hypertension and preeclampsia, hospital emergencies such as venous thromboembolism, hemorrhage and sepsis, outpatient care including obstetric ultrasound and genetic testing, and information gaps in future research. They provided a brief overview of each topic, quality measures discussed, and new measures that were recommended for consideration. Using quality measures for improvement involves 6 steps. The first is to identify a deficiency or an area of improvement. Next is to select a measure to assess this area, obtain pre-intervention baseline data, perform the intervention, perform post-intervention measurements, and refine the measurement and the intervention. Once you have identified an area of improvement, it is critical to set goals to establish a clear pathway for implementation and achieving your goal. Employing the SMART goal setting technique helps bring structure to your goals. The goal should be specific, clear, and unambiguous. It should be measurable and clearly define how you'll measure progress towards completion of your goal. It should be attainable. Setting lofty, unattainable goals is an easy thing to do when seeking to evoke big change. However, it is critical to remember that goals should not be so lofty that they're unattainable. Goals should be challenging but not unrealistic. They must be relevant to those involved, otherwise it will not get the support that it needs. And it must be accomplished given the resources that you have, time, money, and expertise. And it should be time-bound. A goal must have a deadline for completion that you will aim to meet. It may also have multiple short-term deadlines so that you can make small progress on the way to achieving your large goal. The driver diagram is used to identify factors that influence the achievement of a goal. It serves as a tool for building and testing your theories for improvement and movement towards the desired outcome. Here is an example of a driver diagram as we implemented pause before pushing. The outcome that we chose was to decrease maternal morbidity from obstetric hemorrhage from a vaginal delivery by 25% from January 1st, 2016 to January 1st, 2018. A primary driver was the recognition and prevention of OB hemorrhage for all patients undergoing a vaginal delivery. In order to achieve this goal, we wanted to assess the hemorrhage risk on admission and when the patient achieves 10 centimeters dilation. We want to have a system in place to quantify the blood loss, and we want to actively manage the 3rd stage of labor. Action steps including an identification of a hemorrhage risk assessment tool, and again, this is our pause before pushing. tools for reliable quantification of blood loss, engagement of the OB providers and the nurses on quantitative blood loss measurement, and develop a policy for the management of the the third stage of labor. As I've alluded to, one of the quality improvements and projects that we've implemented in the last year is pause before pushing. Our goal for pause before pushing was to improve the identification of risk factors for postpartum hemorrhage in patients undergoing a vaginal delivery, taking into account all of the changes that may have occurred throughout the labor process. Following the 6 steps outlined previously, we identified a problem and determined an actionable risk reduction strategy. In our case, pause before pushing would have identified our patient with increased risk due to prior uterine surgery, a prolonged induction course, use of magnesium sulfate for the treatment of HELLP syndrome, abnormal platelet function, as well as contraindications to specific uterotonics. We would have also noted that the patient was not typed and crossed and did not have blood readily available. Approximately 6 months after implementation of pause before pushing, we will obtain post-intervention measurements. These include estimated blood loss as well as a hemoglobin and a hematocrit on postpartum day 1. This is an example of the pause before pushing sign that is located at the head of each bed in the labor and delivery suite. It is designed to be completed and verbalized by the physician and the nurse taking care of the patient when the patient achieves 10 centimeter dilation. The P stands for patient-related factors, including parity, BMI, medical contraindications for uterotonics, and prior obstetric hemorrhage. The U stands for uterus and reviews an abnormal labor, whether it's been protracted or fast, presence of chorioamnionitis, uterine distension from multiple gestation, macrosomia, or polyhydramnios, or the presence of fibroids or prior uterine surgery. S is for our safeguards, so whether or not we have readily access to the hemorrhage cart, is there Pitocin in the room for the active management of the third stage of labor, does the patient have a working IV and how many IVs do they have, and is there an OR available? Lastly, the H is related to hematology, and it prompts the team to know the hemoglobin and the hematocrit of the patient, if the patient has a bleeding disorder, if they're currently on any anticoagulation, or whether the patient accepts blood products, and if there's a type in screen or blood available. PDSA stands for Plan, Do, Study, and Act, and is a model that you can use to manage improvements and test your identified theories to determine whether or not they generate an improvement towards your goal. Your project becomes a series of small sequential trials of experiments in which you are rapidly testing and then refining your ideas to achieve your desired outcome. Effective measurement is critical. If you don't measure, how will you know that an improvement has occurred? An effective way to visualize a trend is a run chart. Run charts allow us to understand objectively if changes we make to a process or system over time lead to improvements. Because of the utility and simplicity, the run chart has wide potential application in healthcare. Using run chart, one is able to see a small change following implementation of a new protocol. Individuals are more likely to remain engaged and continue to participate in a particular quality improvement if they see that progress is being made. The Institute of Healthcare Improvement has developed a free tool to aid organizations in tracking this data. This is called the Improvement Tracker. Through the Improvement Tracker, you can either select from a list of existing measures or input your own, set your aim, and input your data. Once you do this, the tracker generates a run chart to visualize the trend. It allows for the generation of custom reports and depending on the needs of your organization. With the remaining time, I'd like to review several of the quality improvement projects in our department. Pioneered by one of the ICU fellows and in collaboration with OB, anesthesia, critical care and NICU, we recently published guidelines for the care of the critically ill obstetric patient. These guidelines provide a detailed description regarding the transfer of critically ill obstetric patients to the appropriate ICU. These guidelines, which are available on the intranet, walk you through the transfer process, including the contact numbers for each ICU, personnel to contact to physically transport your patient, and provide an example of the antepartum and postpartum hard stops that the team is required to perform at the time of handoff. The hard stops include parameters for when to notify the OB team and display critical information including gestational age, anticipated mode of delivery, and pertinent medical and surgical history. This information can be referenced quickly in the event of an emergency. Here I've provided an example of the antepartum hard stop and the postpartum hard stop. Completion of these hard stops, as well as ensuring that equipment such as the neonatal warmer and delivery supplies and emergency plans in place should the mother or the fetus acutely decompensate, are quality measures falling under the umbrella of structure and process. 1, does the infrastructure in the different ICUs allow for the obstetrical and neonatal resuscitation supplies? And 2, are the hard stops being used every time an obstetric patient is being transferred to the ICU? Similar to the ICU hard stop, the OB anesthesia team developed an OB PACU hard stop to be used at the end of every procedure being performed on labor and delivery. The hard stop facilitates communication between the OB and the anesthesia team with regards to intraoperative management and postpartum goals. And lastly, I believe that everyone is familiar with the Complex or COST program. The COST program was designed to identify and treat patients that will require complex surgery with a multidisciplinary approach. The goals of the COST program are to regionalize patient care, improve preoperative assessment, develop a comprehensive surgical plan, and reduce surgical morbidity. The COST program includes women with a history of 4 or more prior cesarean deliveries, morbidly adherent placenta, placenta previa, BMI greater than 50, exit procedures, and abdominal sarcophagus, as well as a history of multiple abdominal procedures. The COST program was established in 2014, and we have been collecting outcome measures since implementation. Several of these outcome measures include planned versus urgent procedure, estimated blood loss, rate of transfusion, ICU admission, intra and postoperative complications, and reoperation rates. Outcomes were compared to those similar diagnoses for 3 years prior to implementation of the program. Since implementation of the COST program, for patients with morbidly adherent placenta, the estimated blood loss has been decreased by 40%, use of blood products has fallen by 60 to 70%, we've had a reduction in the admissions to the intensive care unit, and a decrease in our intraoperative complication rate, such as bladder injury. I'd like to thank you very much for your creativity and participation in the multiple quality improvement projects going on in our division as we continue to strive to provide a culture of safety for our patients. I'm happy to take any questions at this time. No questions? Okay. Yes, your phone?
I think one of the problems with the quality improvement process
Could you speak up, please, Doctor?
I'm trying. So I think one of the difficulties is really identifying the issue and also having the available data to see what the problem has been in order to compare to the type of information. So I'm curious what you think are the things that we need to keep track of better on the grand delivery of this general that how we
Yeah, I don't know. I mean, that's a very difficult question. I think when you want to implement a quality improvement project, and I know this has been in my experience in the past, that you get so excited about the implementation phase that you sort of bypass obtaining the pre-implementation baseline data. And I think that's a critical step, and this has, preparing this has kind of given me the opportunity to step back and just actually think out the entire process as opposed to just implement and then collect data. So I think it's hard to say, like, what should we do better about collecting on labor and delivery, because it's very broad and you're not going to know what in particular you're doing for a quality improvement project. But I think actually taking the time to plan through and identify what you want to use as your measure and obtaining that data is really important.
There is looking at certified topics, for example, postpartum care. Use this right in your note. It's hard to extract that data out of the patient's chart. But if you put that into a topic, that is very easily for the rest of the
Yeah. Absolutely, as opposed to just free texting things and we can't extract that information. Thanks.
Well, that, I mean, the subject of extracting data from EPIC needs to be a constant point of discussion in all our concepts about research, patient safety, or even patient satisfaction. Because in terms of data repository, EPIC is not only poor, so 1 on a scale of 1 to 5 in terms of excellence, reliability, reproducibility. It's also dangerous because it allows erroneous information at the same level and frequency as it allows accuracy. There's no field limit, there's no restriction on free text. It's not a data. So I think the old style of learning things about patients is to review records. And this is even more difficult because of EPIC and its ability to hide information because it's not on the same screen all the time. So I think we face a real problem of achieving those data sets. And it's going to require specific data collection by a motivated set of research to produce really accurate things. So I don't think that we should base our assessment on the electronic medical record as it currently is applied. We have some hope that in the future, maybe not immediate, but in the next 2 to 4 years, that modifications to EPIC and more stringent guidelines about free texting will actually achieve something. But one of our failings in our department, shared by many other departments, is the freestyle attitude towards patient entry, which is permissive because the faculty don't police the members of their team. But it's insidious because every new generation of interns reinvents how they want to record things. And so poor Dr. Mark, who has been swimming against the tide for the last year, trying to get you all to enter things in the flow sheet, which can be analyzed and collected and have values assigned, is perpetually defeated by a new wave of I'd rather write it this way. And I'm afraid that that's directly addressing Dr. Gale's question and means that our experience with EPIC is not producing data-grade entry. It's producing like random, heterogeneous scribbling. So it's even worse than the paper format which used to have headings on each on the paper. So you'll notice in the department over the next 12 months a really determined effort to enforce data-grade entries, the patient's charts and correspondence to the flow sheets, and that's one of the major reasons for us moving to a completely new record system, which will integrate with the heart rate monitoring system, recording and interpretation of fetal heart rate. So that was a long speech. Thanks for listening. I want to just caution all the researchers in the department, which interestingly include all the people who are making these random free text entries, that taking EPIC literally is extremely dangerous and probably actually impairs patient safety. So one of the important issues of your presentation is the dialogue that happens, both debriefings and planning our measures as we move forward. And the pause before pushing, for example, was designed not to take place in the quiet room or some team room, but actually at the foot of the bed so the patient and usually her partner can also participate. And that's going to be an important rescue mechanism from the danger of that. Thank you very much.